Hi, thank you for attending my talk this morning. The topic today is management of refractory septic shock. Now, before we get into management of the refractory shock state, we'll review the basics of shock, and we'll also review the known recommended agents to use in shock prior to proceeding to what do we do when the guidelines no longer exist for our patients. So the objectives, again, we'll review types of circulatory shock and the hemodynamics associated with them. We'll review the pharmacology of vasoactive medications to manage shock as recommended by the current surviving sepsis guidelines. And then we'll review management of circulatory shock refractory to vasoactive medications that are currently recommended. So again, what to do when there are no guidelines left. Our goals here, of course, are to reduce mortality and morbidity in patients with a good prognosis based upon the SOFA score and their comorbidities. And to do this, we'll interweave a case example throughout this talk, and that's going to be of a 31-year-old female teacher who presents with flu and superimposed bacterial pneumonia in septic shock and respiratory failure, who's previously healthy and now is requiring vasopressors in the ICU. So to start with, let's review the different types of circulatory shock. So note here in red to start with, septic shock is by far the most common cause. And here I'll bring your attention over to first the subsection B here to review the types of shock. And here we see that 62% of shocks are distributive of the septic nature. And then only a smaller minority is distributed of a non-septic nature. Maybe here think of like allergic reactions. About 16% are related to cardiogenic shock. About 16% are hypovolemic, maybe think GI bleeds. And 2% are maybe obstructive, think maybe pulmonary embolism or maybe a pericardial tamponade situation. And so as we look at this, first we'll come over here now to A, and we'll look at, is there arterial hypotension? And the first question we need to ask ourselves is there signs of tissue hyperperfusion? So there might not be. And if there are no signs of tissue hyperperfusion, perhaps maybe this is just simply chronic hypotension. I mean, how often are we called to the emergency department to evaluate a patient who has a systolic blood pressure of 90? They're looking at you, you're looking at them, and they're like, why are you even talking to me? What are we talking about critical care for? I feel fine. And that could pretty much be just where they live. They probably have a lactic level of 0.7 and they're fine. Or maybe was this just something that was very brief and transient, maybe like a syncopal event. So here, what if they do have arterial hypotension? They have signs of tissue hyperperfusion. Well, what are some of those signs of tissue hyperperfusion? Well, you could have altered mental status in the brain. The skin can become mottled and clammy. You can have decreased urine output in the kidneys. Of course, you can have a tachycardia that compensate for the low blood pressure, and you can start having elevated levels of blood lactate. So here then, if these are present, this gives rise to circulatory shock. And really what we want to do at this point in time now is estimate the cardiac output or the SVO2. And so let's follow this right here. So if we have a normal or high cardiac output or SVO2, one of the first things here we're going to consider is this distributive shock. So in this particular example, the SVO2 could be normal or high because we'll have shunting, and we'll review that. And the cardiac output is usually compensatory and increased because you're trying to compensate for that decreased SVR, which we'll go over. And then note here, we have echocardiography listed here. It's important that we as critical care doctors are able to look at the heart these days. There are now, per the National Board of Echocardiography, board certification exams for critical care doctors to develop this skill, improve their competency. And this is important because this is information that we need to know to be able to accurately to put people into the right categories and to treat them. So here, let's see now if the patient has a low cardiac output. And let's first say they have a low CVP. Well, what are we thinking with a low CVP here? Here, during echocardiography, we'll see things like small cardiac chambers and maybe normal or high contractility, but it's really the small cardiac chambers that is telling me that this is a decreased volume state. This is hypovolemic shock. Or here, if we have a high CVP, we can maybe have a cardiogenic shock where the heart's just not pumping well. And when we look at the heart, we have large ventricles because the heart is trying to fill, and it's filling well, but it can't contract well. So you see large ventricles and poor contractility. Or maybe we can see obstructive shock, say like in tamponade. Pericardial effusion will have small right and left ventricles, and we'll have a dilated vena cava because we just can't get the blood into the heart because it's being squeezed. Or say in pulmonary embolism or pneumothorax, we can have a dilated right ventricle only because we're having a hard time getting blood past the lungs and maybe a small left ventricle. So it's important to note here that many patients have multiple types of shock. And so it's important to rule out all types because multiple types could be present. And here again, the hemodynamic and clinical exam evaluation of cardiac function is essential to optimal management. And really, echocardiography needs to be a skill that we all master. So let's review some of the pathophysiology of severe sepsis a bit here. So at the level of the capillaries, what happens? We have a microvascular dysfunction. It's this capillary membrane that gets disrupted. And because of that, we can see an increase in inflammation. And because of the increase in inflammation, we have increased coagulation and a decreased fibrinolysis. What does this ultimately give rise to? Well, hypoxia and hypoperfusion. This is largely due to a microvascular thrombosis at this level, again, because of the increased coagulation and decreased fibrinolysis. This gives rise to a capillary leak as we disrupt this membrane, and this is ultimately endothelial damage. And what's the end result here? Well, we have organ dysfunction. We have a global hypoxia because we're simply not able to get that oxygen transport across the capillary. And that's why we have that increased SVO2, because we're in essence shunting now. We're not able to transport oxygen out of the blood vessels into the tissues. We have direct organ damage. Then we have a lactic acidosis because since we're shunting oxygen, we're going into anaerobic metabolism at the level of the tissues. And we can have a decreased albumin. It's important to note that albumin is actively transported across the capillary membrane, the capillaries. And in sepsis, where you have disruption of the capillaries, you can have leak of the albumin and give rise to a low albumin state. And ultimately, this could give rise to death if it progresses. So let's review some of the different, let's maybe wrap up and just take another closer look here at hemodynamic shock, a closer look at septic shock, which we're going to turn our attention to, but also one last review of all the different types of shock before we move on. So in septic shock, it's a distributive shock. The cardiac index is usually high, greater than 3 liters or 3 liters or so. And think that since your primary problem here is a decrease in SVR, a decrease in peripheral vascular resistance, the heart is compensating. Again, we see a low vascular resistance, and we can say you have a decreased SVR, systemic vascular resistance, or in some different monitors that might be commonly used today, such as the NICOM or the CHEETAH monitor, we look at a total peripheral vascular resistance. We can have hypovolemia. Again, this is due to capillary leak, in which we have, my apologies, in which we have cold or mottled extremities. Lactic acid levels are commonly greater than 4. And interestingly, this could be due to hypoperfusion, or you might not have hypoperfusion and you could still have lactic acid levels that are elevated, again, because the capillary membranes are damaged and you have that shunting across. Mortality can be high. And this is a last review here of some of the different types of shock. Again, this is nice before we'll wrap this topic up. So in cardiogenic shock, we can have a decreased cardiac output because the heart's not pumping well, increased filling pressures, again, because the heart's not pumping well and being overfilled. To try to compensate, you have an increased vascular resistance, and because you have poor cardiac index and cardiac output, you have a low SVO2. In hypovolemia, you have decreased cardiac output because you're just not filling the heart well, you have decreased filling pressures. The vasculature tries to compensate, you have increased SVR, and again, since you have a low cardiac output, cardiac index, you can have a low SVO2. In distributive shock, well, the real problem here is in the decreased vascular resistance, and so the heart can try to compensate, and so you can have increased cardiac output. You can have normal or decreased filling pressures depending on how bad the shock is, and here SVO2 will be elevated again because of the shunt at the level of the capillaries. And then obstructive shock, you have a decreased cardiac output, often high filling pressures to try to compensate for the obstruction. The vasculature tries to compensate. You have an increased vascular resistance. And the SVO2 is decreased because you have a low cardiac index and low cardiac output. So now let's bridge over into the pharmacology of some of our drugs. And the first one we're going to take a look at here is norepinephrine. So per the surviving sepsis guidelines, one of the first things we're going to do is an initial fluid bolus, which is currently recommended per their guidelines, 20 to 30 mLs per kilogram. This is a little outside this talk, but oftentimes some centers use more. They recommend then to start vasopressor if the MAP is less than 65. And what's the first initial drug they're going to recommend here? Norepinephrine. And we'll take a look at maybe when to start norepinephrine on the next slide. But for here, they recommend to start it if the MAP is less than 65. And they recommend to keep MAP greater than 65 for renal perfusion. And then here again, since we have a problem in our sepsis of distributive shock, we have a decreased SVR, we want to work on alpha receptors. So alpha receptors is going to increase, it's going to cause vasoconstriction of the arterial vascular tree and increase our SVR. And so the alpha receptors are found actually both on the venous and arterial side. And of note here, and I'll mention it because it was so widely used prior, that the use of dopamine now is only recommended if bradycardia is present. As was commonly once used, dopamine was used for quote unquote renal protection to increase urine output. There's no role for that anymore. And maybe common to many anesthesiologists who practice critical care. We're so used to phenylephrine that we use in the operating room all the time, but there's no mention of phenylephrine in the guidelines. So here's a nice overview before we go into depth for all of these agents here. And this just takes a look at increased SVR, which is related to an alpha effect, where say phenylephrine is about as pure as an alpha agent as we're going to get. And then the reverse effect that when we increase SVR, we can have a decreased cardiac output. Say with phenylephrine, we have a reflex bradycardia we get, and that's why you have a decreased cardiac output. And the relationship between these two, between SVR and cardiac output. Taken on the other extreme, we have milrinone down here, which will increase cardiac output, but actually decrease SVR. So the nice graphs here showing the converse relationship between SVR and cardiac output. And again, we'll take a deeper dive into these agents. So here's our first deeper dive into norepinephrine. And I'll first bring your attention over here to where norepinephrine is predominantly an alpha-1 agent. Now, if you were to use just a pure alpha-1 agent, again, like phenylephrine, the effect on the heart would be a reflex bradycardia, and we don't want that. We want to preserve cardiac output. And so here, norepinephrine has some beta-1 activity, but in clinical practice, it has just enough beta activity to prevent the reflex bradycardia. And in clinical practice, you do not get a tachycardia with this medication. So just to be complete over here, the effect is vasoconstriction. It increases the MAP because sepsis causes severe vasodilated state and a decreased SVR. Again, it's the first-line agent per surviving sepsis guidelines. It's predominantly an alpha-1 agent, as I mentioned over here. So the recommended dose is anywhere from 0 to 90 mics per minute if you use that measurement, or, as over here, 0.01 to 3 mics per kilo per minute. However, it's important to note that when you get, say, above 0.5 mics per kilo per minute, or say above 20 or 30 mics per minute, you're not likely to get any additional benefit. And that's because you're saturating all of your alpha agents already. Now, you could go higher. It's just important to keep in mind that when you go higher, you're probably not going to get added benefit. You really should be thinking of multimodal treatment at the time, but you do risk bowel ischemia and coronary ischemia, so complications could go up. Again, the norepinephrine mitigates, does not cause a reflex bradycardia, and in clinical practice, you do not get tachycardia. And this is a catecholamine, and it works best with a pH above 7.2. Of note here, this says mitigates reflex bradycardia. Sorry for that error. And then to repeat one more time down here, this works best with a pH above 7.2. This means that our catecholamines do not work well in an acidotic state. And that's something to keep in mind when we review some of the refractory treatments. Since the catecholamines don't work well in an acidotic state, maybe considering actively treating this with continuous infusions might be a way to treat refractory shock. So per the surviving sepsis guidelines, vasopressors are recommended if someone is not responsive to fluid, but these questions are constantly being asked. Is that the appropriate route? Maybe should we be starting vasopressors earlier? And this was an interesting paper. And so here we have our case example again, our 31-year-old female. She received fluid. She's had a MAP less than 65 after fluid. And the question is when to start vasopressors, and maybe starting earlier is better. And so what this particular paper did is that when you were diagnosed with sepsis, pressors were started, norepinephrine specifically, at a fixed dose of 5 mics per minute. And this could be run in a peripheral IV, no need for a central line. And it was interesting to see the results. And so I'll jump down here to the conclusion first, and then we'll go into some of the weeds with the main results. And that is that by starting norepinephrine at the get-go, there was early norepinephrine was significantly associated with increased shock control by 6 hours. This is interesting. When it comes to the main results, I do have to note here that there was not a mortality benefit between the two, but we did find in the early norepinephrine group, this was associated with lower instances of cardiogenic pulmonary edema, less fluids needed to be given, and we now know that too much fluid has a mortality risk in these patients. And also there is decreased incidence of new onset arrhythmia. Again, shock was controlled sooner, so the heart had to work less to compensate, so less arrhythmias. So very interesting question, when to start vasopressors, and it appears maybe that earlier might be better. So now let's move on. So we continue with our persistent shock state here. We have our 31-year-old female again, and she got her 30 cc's per kilo lactate Ringer's bolus. She got an additional 500 mLs of albumin. She's on 30 mics of norepinephrine, and she's still hypotensive. So per the surviving sepsis guidelines, what should we do next? Well, first, it's really important here is that the patient should be examined for their fluid responsiveness. Maybe 30 cc's per kilo is not enough. Maybe it was too much. But the only way to know is to do some type of dynamic assessment. So echocardiography, or maybe using some of the non-invasive monitors, such as the Nikon monitor, to assess fluid responsiveness. Because again, you just don't want to give fluid to an individual if they don't need it, because that fluid can be associated with an increased mortality risk if they don't need it. So in this particular patient here, they were not fluid responsive, say to an additional bolus or to passive leg raise. And so what to do next? So then per the surviving sepsis guidelines, we're going to add a vasopressin drip. So what is vasopressin's role in septic shock? Well, here we'll take a look that vasopressin works not on the catecholamine receptors, but on V1 and V2 receptors. And particularly here, V1 receptors is going to increase our SVR. So let's a closer look here. So vasopressin is a hormone released by the posterior part of our pituitary. And in sepsis, you can have a dysfunction of the hypothalamic pituitary axis, and we're thought to have a relative deficiency in sepsis. And so we usually replace a fixed dose of 0.04, and this is thought to replace again the natural vasopressin level that we don't have in the septic shock state. It is, per the surviving sepsis guidelines, the recommended second-line agent in sepsis. And there's a question of whether or not it has a synergistic effect with norepinephrine as per the VAST trial from Canada. So again, this works via V1 receptors to increase SVR. And it's interesting to note here that there are no V1 receptors in the pulmonary vascular tree. So this could be important for us, and we could maybe manipulate this use. In select cases, maybe we have someone with a stage 4 pulmonary hypertension who happens to be in septic shock with a decreased SVR state. And by increasing their pulmonary vascular resistance more, we could dramatically reduce their cardiac output because they might go into worsening right heart failure. So this could be a unique situation in which maybe we use vasopressin as a pressor. And to do so, we might consider here going up to dosages as high as 0.1. So again, outside of the replacement level, but and now into higher dosages. And again, this might be justified based on select cases. But just like with norepinephrine, when we went up to high levels, we do have to have caution of increased complications with valve ischemia and myocardial ischemia. So we're constantly weighing the risk versus benefits, but this is an interesting thing to note that it does not affect pulmonary vascular resistance, and we might need that in select cases. Now, since this is not a catecholamine, it's interesting to note that this works well with a pH of less than 7.2. So again, this could come in handy if we're dealing with a refractory acidotic state. we might want to increase the vasopressin level temporarily. And also vasopressin might have the potential for decreased risk of renal injury.